on to the keynote lecture. The topic is lipohypertrophy, an important aspect of insulin injection therapy. The speaker will be Dr. Rakesh Parikh. Dr. Rakesh Parikh is a fellow of the American College of Endo, Royal College of Physicians, Glasgow, College of Physicians of Bombay, and the RSSDI. He's a member of the Executive Committee and a founder of the Metabolic Society, Jaipur. Also a co-founder of DTech. So he wears multiple hats, editor, reviewer, and I would say technocrat in the field of diabetes. And this is a very interesting topic, I think, because how many of us have actually seen lipohypertrophy in our patients? Yes, I know. So I know when I gave my exam, my examiner, Professor B.K. Sahai, asked me, have you examined, what do you examine in a patient to see who is on insulin? And this is the most important thing, which is usually neglected. So, right. Hoping to hear something new about that.
Sure. Thank you, ma'am. Thank you for such nice words, and thank you, Dr. Jyotidev sir, JPEF team, for inviting me here. And as rightly asked by Dr. Lotika, ma'am, we don't usually look for lipohypertrophy. I did raise my hand, but I also do it only when I suspect there is something wrong. A patient who is requiring higher doses or who is having a lot of fluctuations, then I examine and look for lipohypertrophy. But while preparing this talk, I realized that I think we should do it more often and more frequently in all our patients who are on insulin. I'll try to talk about the importance of that aspect in next few slides. These are my disclosures. So the agenda for today's talk will talk about Fitter Forward, which is the latest document published this year itself in April by Mayo Clinic, and it has got some updates about the insulin injection techniques recommendations. Then we'll talk about lipohypertrophy, which is a long-standing complication of insulin injection that we all know about, and what are the current Fitter Forward recommendations to prevent it. We'll also talk about the risk factors and how to identify people who are developing lipohypertrophy, and then we'll review about how it affects the insulin absorption and discuss some best practices to address this particular problem. So this is the ongoing process which has been going on for last around 20 years now, more than 20 years actually. So it started with 1997 when there was a first meeting which was on insulin injection technique. It was a workshop and it was published in Practical Diabetes International. It was then followed in 2002 by another publication which was in the same journal, and then in 2010 they came up with Titan, which is third injection technique workshop in Athens, and that was again published in Diabetes Metabolism. The one prior to the current one was Fitter, which was very popular, and it was conducted by doing an consensus meeting in which there were 183 experts from 54 countries who gathered together, and they discussed on various aspects of insulin injection technique, and they came up with a document that was published as well as cited by so many other articles, and even in the ADA standard of care it has been cited. Now the latest one is the revision of this, which was around 8 years old, and that is Fitter Forward, which was again a consensus which has been arrived by a virtual workshop, and then it is published by Mayo Clinic Proceedings. We'll talk about that latest article. Again, the document is available at Embecta stall, and there are Embecta people here. Yeah, Kaiser. So these are the people who are Embecta people, and they have the hard copies of the Fitter Forward guidelines. Those of you who are interested, they can take the copies from them or from the Embecta stall also. Components of these recommendations. First one is addressing the factors which influence the injection experience, the phobia of needles, the pain associated with the injection, and then the people with diabetes talk about their technique characteristics also factor into the experience. So how the technique is applied for insulin injection, that is also important. That is one component of the guidelines. The second is evidence-based injection technique procedures, starting from the storage, handling and disposal of the devices, injections, needles, syringes, selection, preparation and rotation of site, and also proper injection technique for the pens as well as for the syringes. Then risk reduction and detection of lipohypertrophy, who are the people at at risk, how to detect these people, and how to prevent the development of lipohypertrophy in such people. And fourth aspect is specifically about the training and education. So all the SCPs, the educators who work with you, they should be optimally trained to teach their patients regarding the proper injection technique, and that should be evidence-based, and this has to be done repeatedly. And for that, again, there are some tools. There is a tool called Lipo tool, I guess. So that tool, those of you who have not practically seen lipohypertrophy many times and want to get a feel of what lipohypertrophy is, they have a tool in which you can understand how the normal skin and how is the lipohypertrophy. Yeah, that is the tool here. So, and then they also have a lipo rotation, for the injection site rotation, you can use this tool. This is supplied by many insulin companies also, but this is a tool which will give you a feel of how the lipohypertrophied skin feels in the people who are developing it. That tool also you can see after the talk. So these are the 4 components of these fitter forward guidelines. And one of the important components which we often ignore is about the needle length, which is actually very critical if you want to have a proper effect of insulin. Now, in most of the people, majority of the people, the skin thickness is 2.2 mm, regardless of whether the person is obese or lean and thin. So a 4 mm needle is the optimum length of needle for most of the patients. By using that needle size, you don't reach the muscle, at least in the normal people. Only in people who are very lean and thin, there might be a chance of going into muscle. So that time you need to do the skin pinching. Otherwise, for a normal person, if you are using a 4 mm needle, you don't need the skin pinch now anymore. You just can inject the your pain or in syringe directly. Some people who are having a skin thick, very rarely, there you might need a 5 mm or 6 mm needle also, which is also available. So this needle length is an important component that we must remember. We should not go for those 6 mm syringes which have been used in past. The second component is the needle itself. How is the diameter of the needle? So earlier we were using thicker needles. Now the ultra thin needles are available. More the gauge, lesser is the diameter of the needle. So the current one that we are using is the 32 gauge needle, which is the recommended one for all the adults with diabetes. And it is basically the diameter or the outer diameter of the needle. So 32 gauge is this size. Now the 32 gauge needle also can be of 2 types. One can be having a regular wall like this, and the other one will be ultra thin wall. So if you use an ultra thin wall, then at the same diameter you get more lumen, and by having more lumen in the needle, the pressure reduces. So the insulin doesn't go with a lot of pressure, reducing the pain and having the better experience for the patient. So the needle diameter, the recommendation is 32 gauge, and in that, preferably you should go for a needle which is having ultra thin wall. The second aspect is the sharpness. So earlier we were having 3 bevel needles, and now the latest one are 5 bevel needles. So if you have 5 bevels like this, which are edges, so with the needles which are sharp and having 5 bevels, you get lesser pain and a better patient experience. And the third one, which I never knew about, is the importance of the base of the needle. So there are these 3 types of bases. I never noticed that. This is the one that is posted, this one is the flat, and the ideal one is the contoured one. So if you have a contoured needle base, then the pressure distribution is even and the injection is proper. You will not see a lot of variations in the insulin doses. The pain will be less also. So now we'll come to lipodystrophy. So lipodystrophy is a general term, and it can be, the most common is lipohypertrophy, where there is an excessive deposition of fat because of regular insulin uses at the same site. Some patients might have lipoatrophy. I didn't see many patients with that, and some might also develop amyloidosis, which is not a deposition of fat but amyloids. So lipohypertrophy, if you develop, then it increases the risk of hypoglycemias as well as hyperglycemias. So if the patient is injecting insulin at the lipohypertrophied site, the insulin absorption will be less and the sugar levels will go up. Sugar levels go up, you increase the dose, the patient injects at the normal site, he goes into hypo. So these hypers and variations often happen in such patients, and in those patients at least, you must look for the site, whether the injection site is having lipohypertrophy or not. And believe me, when you look for this in patients who are having these fluctuations, many times you'll find it. So not by inspection alone, but if you palpate it properly, you'll find it. So how do you find it? Basically, lipohypertrophy is just like this, excessive adipocytes, which can be in any of these forms. So sometimes they can be like this, where there is a nodule, but you will not see it visibly. So on the skin, by inspection, you may not be able to detect anything unless you palpate it. Sometimes it is again a very small nodule, not visible, but if you palpate, you'll find it out, and sometimes it's very obvious. So some people would be having a lump like this, which is visibly obvious at the insulin injection site. That's a lipohypertrophy. But then in some patients, you can just take the pinch and then you can palpate, and you will probably get some nodules which are there. So the most common factors which are responsible for this are the incorrect rotation. If you keep on injecting at the same site, that will happen. The longer duration of insulin uses, people who are using it for 10 years, 15 years, it's very common. So I often ask this question to my patients. Do you rotate the site? You have to rotate the site. And they'll say, yes, I do it. So in the morning, I put it here. In the evening, I put it here. Habitually, the hand goes at the same place. So that we must remember that if you are doing it involuntarily, your hand will go at the same place every time. So you must ask them either to use a tool like this, where they can, rotate the site with 1 centimeter every time, or tell them that don't become habitual to a particular point. Keep rotating that. So again, we'll talk about that in the next few slides also. So first, before that, how to identify lipohypertrophy. As I said earlier, it can be detected very easily just by visual inspection. If it is a visible, lipohypertrophy, sometimes you might need to palpate, but by palpation, majority of people you can identify it easily. The gold standard, although, is ultrasound scans, but I don't think we'll go for ultrasound scans for detecting only lipohypertrophy. It is used for research purposes. Clinically, I don't know how relevant it is, but it is not difficult. If you just palpate, you can easily identify it. So visual inspection and palpation is inexpensive, and it helps us to identify the lipohypertrophy lesions easily and correctly. Now, the diagnosis and management of lipohypertrophy, visual inspection and palpation of the sites, as I said earlier. If detected, we must document the size and the position of lipohypertrophy. So we should document on our records where the lipohypertrophy was identified, what is the size, and then we should ask the patient to avoid that site at least for 3 to 6 months, or till the time it is resolved. And after that, the patient can again use that site. We should also monitor the blood glucose levels more frequently, because the insulin doses might need to be reduced. If the patient was using it at the lipohypertrophy side, he was requiring higher doses. Once you change it, the requirement might go down, and the sugar might go into, the patient might go into hypoglycemia. So that we must advise. So if you are sure that a patient is injecting in lipohypertrophy site, having normal sugar levels, advise lower doses of insulin on the safer side, and ask him to monitor and then increase if required. So this is how we all are aware of these. These are the sites for the insulin injection, and the process for rotation is that you can either use a tool like this, or you can keep rotating it by 1 centimeter. I think there's a next slide on that. So any site which has got a sufficient sub-Q fat, you can use it so that you avoid the intramuscular injections. The site should be clean, intact skin surface. It should be free from any scars, tattoos, or lesions, or any site of lipohypertrophy. For rotation, we can use this method. First is that ask them to rotate by 1 centimeter every time, and secondly, go in a particular fashion. So if you are going clockwise, then continue clockwise. Don't do that once you go clockwise and then come back anti-clockwise. It will be the same site again. So that must be emphasized upon, and the patient should be advised to change the zones. So they can use one zone at a time and then another zone for another injection, or you can rotate that on a weekly basis or something like that. So somehow you ensure that the patient is not using insulin at the same site every time, and that if you do that properly, then you can definitely avoid the lipohypertrophy. Lipohypertrophy might definitely interfere with the glycemic control, and it can increase the insulin requirement, as we discussed earlier. You might see that the patients will be having higher A1Cs than expected, and they will have more frequent unexplained hypoglycemias. So A1C is 8.5 and patient is getting hypoglycemias. You either put the patient on CGM, or you will see that there are fluctuations. On a particular day, the sugars are normal. On some other day, they are high. On some other day, they are low. And it might be because of accidentally, if they are injecting the lipohypertrophy site, the sugar levels will go high. And if they increase the dose and put at a normal site, the sugars will go down. So that is the reason for the glucose variability that we see in these patients. And the total dose of insulin will be higher if they are using the lipohypertrophy site very frequently. So this was a study where they looked at the actual effect of insulin absorption at a normal adipose site and at the lipohypertrophy site. So when they injected insulin at a normal skin, this was the insulin response. And then when they used it at a lipohypertrophy site, this was the response. So the insulin levels were lower if you use at the lipohypertrophic site, and they were lower by 21%, which is very significant, and that is why the patient would be requiring higher doses to control the blood sugar levels. So this was there, but the effect of this much 20% lower insulin levels is very high or significant when you look at the glycemic response. So in the same study, when you look at the glucose levels of the patient and compare the glucose levels after injecting at a lipohypertrophic site and at a normal site, the difference is very high, which is 70% higher if you are injecting at a lipohypertrophic site. So that is why it is important to understand the lipohypertrophy and to prevent that in our patients. So how do you, what are the risk factors for this, the important risk factors? So this is a study where actually they did a survey and they found that the 30% of patients, they had lipohypertrophy, and 44% of these patients said they were injecting into the lipohypertrophic site. So understand this, if they are injecting into that site, 44% of patients are requiring higher dose of insulin, wasting the insulin, still sugars are high, and accidentally if they inject at a normal site, they will go into hypoglycemia. And these are the three independent risk factors which are significantly associated with the lipohypertrophy. The first one is reuse of pain needles. So ideally all the guidelines say that we should use the pain needle only for one single use. We cannot use it even for second time, but most of us tell our patients to use it for 2-3 times, which is again not ideal, but maybe for economical reasons we tell that. But now if the patients who are affording the costly medicines like GLP-1 analogs, definitely they can afford a needle which is costing 10-12 rupees. So at least for those people we should tell them what is the right and ideal approach, which is to use it only for a single dose. Second important reason for lipohypertrophy is the incorrect site rotation, as I discussed earlier. So it is not just they are injecting on one side once and on the other side and again coming back there. We should tell them it should be a proper rotation in clockwise or anti-clockwise direction by changing the site by 1 centimeter every time. And the third one, which is a risk factor, is the longer duration of insulin therapy. So patients who are having insulin requirement for last 10-12 years, they are definitely at a higher risk of getting the lipohypertrophy. There are other factors like the size of area which is used, even cold insulin. So if the insulin is taken out from refrigerator and immediately used, that cold insulin can predispose the patient for development of lipohypertrophy. Large doses, whether it is a basal insulin or even in CSII, they are at a higher risk, and social determinants are also there. So studies have shown that people who are having lower socioeconomic strata, they are having more chances, and the reasons are obvious. So even I have seen some patients in my practice, if I ask them how many times to use the needle, they will say I'm using it for 15 days. So at most 2 or 3 days is what we recommend them, but they keep using it for 15 days just to save on money, and that is responsible not only for lipohypertrophy but even for higher requirement of doses and poor response in the glycemic control. So these are the three studies, two of them were in Italy and one was in Russia, and in this study they looked at the impact of educating people about the importance of site rotation, and these study results are very impressive. So here they used a structured 15-minute education session, in this they used 45-minute session, and here they used a 1-hour session, and they just looked at the impact of this. So in this education session they compared all these things, the lipo box and the site rotator kit and so on were explained to patients. And then they looked at the effect of that on the A1C, 0.58% reduction at 3 months, 0.1% reduction, and here even 1.7% reduction at this 6 months interval. So this much is the impact of just educating patient regarding the importance of proper site rotation and proper injection technique. Okay. Yeah, so what are the barriers? One of those is lack of resources. Many of us do not have enough of time and resources or a team for explaining the people right process of insulin injection. So if you are practicing diabetes, if you have a diabetes clinic, you must ensure that you give enough of time to a patient, at least at the initiation, to explain this, and also at follow-ups. If you can't do it yourself, either have some educator in your clinic. If you can't afford that, then take help of some of the people from the industry. They are very happy to do that. So most of the people from insulin injection companies, they would have someone who is an educator and who can do that job for you. There is information overload, mostly the misinformation which is there in the social media, and then HCPs themselves are not aware. So many of the healthcare professionals, they themselves are not aware about the importance of proper insulin injection technique. So that is the reason I think this workshop has been conducted here, this lecture has been conducted here, so that we become ourselves aware, and then we can educate or create awareness among our patients and our educators also. Now this is an interesting finding. So as I said, I do spend 10-15 minutes every patient whom I am initiating insulin for the first time, and this is what I also see. 75% of them forget it totally. You spend a lot of time in explaining them about the titration, rotation, all those things, but when they come back, they do not follow anything, because 75% of the people, they will forget totally, and after a month, 15% only will remember what was told to them. So that is why there is a importance of re-emphasizing, re-educating. Telling them once is not enough. We need to do it repeatedly, and we need to be engaged with the patient on a continuous basis. Maybe you can't do that, but somebody from your educator team can do that. So these are the important aspects while managing patient. In addition to the glycemic control, all the things that we do for that, there is a emotional requirement also. So we have to proactively ask the person who is on insulin how they are feeling about insulin delivery. Do they have renal phobia? Many times they are having doctor phobia also. They will not tell you that they are not injecting insulin. You prescribe it, they will tell I am using insulin, sugars are high, you keep on increasing the doses, they actually are not using it because you never give time to listen to the person. If you ask the patient properly, they will probably tell you that I don't want to take insulin injection because of this and this reason. And then there are social factors like the lifestyle, daily routine of the patient, the physical activity levels, and so on, which might affect the insulin injection technique of the patient. So how do you educate the people? You should do individualized small group training programs, either individually for every patient or call them in groups. And in the educational session, ask the patient himself to demonstrate to you what he has learned. Then we should have some resources which are provided for training, supplemental training. So there are booklets given by the companies, some tools like this that can be distributed to the people, and there has to be an ongoing reappraisal of the technique. So every time the patient comes back, we should ask the patient to demonstrate again what they have learned. We should have a collaboration with the SCPs, educators, patients, caregivers, and families. There has to be individualized instructions factoring in lifestyle, finances, skill, and technical comfort of the patient, and we should give them evidence. Evidence supports that 6 months refresher training and monthly refresher calls help the patients recall better and do better. So to conclude, I think how to know when the patient is, when the review of the training is required. So a person who is experiencing pain while injecting, who is having leaking, bleeding, bruising, it means that there is something wrong. The patient might not be either changing the needles or not using the right site. So if there are any complaints like this, we must review the technique and educate the patient again. If the glucose levels become unstable, hypos and hypers as we discussed earlier, then again we must review this. And we also should take note if insulin or needle refills do not occur as scheduled. So this does not apply to us because we don't keep record of that. But if a patient is requiring more insulin or lesser insulin, those patients we should look for the lipohypertrophy and the insulin injection technique, whether he's following it properly or not. So this is one webinar. People can register by scanning that QR code. It's an online webinar, free to register, and it's specifically on fitter forward. So all these things will be discussed in details in that particular webinar. And there are these international faculties as well as Dr. Sanjay Kalra from India will be in the webinar. You can attend that. I think the registration is free. Kaiser, yeah, it's free and anybody can register that. So at the end, thank you very much. And those of you who are interested to have a look at these things, these are available with Kaiser from Evicta, and also the booklets, he has some copies he'll distribute to you. Thank you.
Thank you so much, Dr. Rakesh Parikh, sir. So it was a very interesting topic on lipohypertrophy, which has been there ever since usage of insulin. So yes, thank you for emphasizing that preventing lipohypertrophy is much more important, and rather than for patients to pick up the problem, get the problem, and then have fluctuating sugars, and then we look for it. So always it is important to educate the patient and tell about this condition, that if you don't rotate the sites and if you don't follow the techniques properly, these things may happen, and then they may be able to remember better and do it better. So any questions from the audience?
It was clear.
Yes, it was very clear.
I think he explained the topic very well. So there are no questions. But
weekly changing the quadrant of weekly change or
yeah, you can do that weekly, but site has to be changed daily, every time. So quadrant you can change weekly basis, but the site of injection you should do it, you change it on daily basis.
So one needle per day is actually practically one needle per day It is actually practically impossible. We will try to.
No, it's easy. So
The cost factor. Cost factor. 1 needle per day.
Needle, yeah. That may be, that might be difficult for everybody, but then there are people who are affording the GLP-1s costing 30,000 per month. So those people at least give the option. Tell them that ideal is to change every time. Okay. And if they can't afford it, of course, they will reuse for 2-3 times, but not more than 2-3 times at least.
Thank you, sir. Thank you.
Okay. So we conclude this session, I think.
Thank you.
Thank you so much.
Thank you.